So moving on to the next session, may I call on stage Dr. Shashank Mishra, and to chair the session, may I call Dr. Shabnam Ruhi. Dr. Shabnam Ruhi has 20 years of experience in her field, and she has received her postgraduate degree from KMC Mangalore. Her areas of clinical expertise include diagnosis of hematological disorders. She has been an assessor for NABL for the past 10 to 12 years. She has multiple certification in hematopathology and quality assurance.
Good afternoon. I think I will read out his introduction. Dr. Shashank Mishra has got an MD from Armed Forces Medical College, Pune. He has a total experience of 6 years after his MD. He is an assistant professor at Command Hospital, Air Force in Bangalore. Assistant professor at Army Hospital Research and Referral in New Delhi from 2018 to 2022. He was an associate professor and HOD of pathology at 5 Air Force Hospital, Assam from 22 to April 22 to November 22. Currently, he is working as a senior resident at Gujarat Cancer and Research Institute, Ahmedabad, and the areas of interest are oncopathology. Welcome, Dr. Shashank Mishra, and over to you.
Thank you so much, ma'am. A very good afternoon to everyone. So, I'll be delivering a talk on the diagnostic utility of high fluorescence cells in serous effusions. As Dr. Simon has already touched upon the use of high fluorescence cells in detection of blast, so I'll be sharing my institute's experience in diagnosing malignant effusions. So, in our institute, we have the BC 6800 Mindray hematology analyzer, which uses forward scatter, side scatter, as well as lateral fluorescence. As we know, forward scatter is proportional to cell size. The side scatter denotes the cytoplasmic granularity, and the lateral fluorescence is proportional to nucleus size. So in this image, we can see a window which is above the monocyte window, where the lateral fluorescence is high. This is the window of high fluorescence cells. So high fluorescence cells have a higher nuclear size than leukocytes. They emit a higher fluorescence. As we know, malignant cells also have a large nuclear size, so they are counted as high fluorescence cells. In body fluids, we have two other important cells which also have a large nuclear size, which are mesothelial cells and macrophages. So these two cells are also counted as a high fluorescence cell. We did this study with the following aims and objectives. Our first aim was to compare the number, the absolute count, as well as the percentage of high fluorescence cells detecting using the body fluid mode of autoanalyzer between malignant as well as non-malignant effusions. Our second aim was to study the sensitivity and specificity of HFC for detection of malignant cells and to determine the ideal cutoff of high fluorescence cells for maximum sensitivity and specificity. We conducted this study in the Department of Oncopathology over a period of 6 months from July 2022 to December 22. Our total sample size was 209 samples, which included 112 pleural effusion samples and 96 ascitic fluid samples, and one sample was drainage fluid. We included all suspected and confirmed cases of carcinomas, sarcomas, as well as hematolymphoid malignancies in our study. We did a total and differential count of all the cases using the body fluid mode. Each sample was simultaneously sent to cytopathology laboratory, where the microscopic examination was performed on Papanicolaou stained slides using centrifuge samples. A cell block was also prepared in cases when feasible, and immunohistochemistry was also performed on these cell blocks when required. Statistical analysis was then performed using R software, and difference in high fluorescence cell count and percentage was assessed between malignant and non-malignant effusions. We used Mann-Whitney U-test to determine the statistical significance, and a p-value of less than 0.05 was considered as significant. cases which were found to be positive for malignant cells on microscopy were taken to be true positives, and those which were found to be negative were taken as true negatives. Then we calculated the sensitivity and specificity of individual high fluorescence cell absolute count as well as percentage using the ROC curve. Optimal cutoff for sensitivity and specificity were determined as the cutoff with the highest sum of sensitivity and specificity and with the highest Jordan's index. In our results, we found that amongst all the cases, 129 were female patients and 80 were male patients. A total of 97 samples, that is 46%, were found to be true positives, and 112 cases were found to be negative on microscopy for malignant cells. We found that the most common primary site in cases of malignant effusions was ovary. The second most common was hematolymphoid, followed by breast and lung. We found that in malignant samples, the absolute high fluorescence cell count was significantly higher than in non-malignant effusions. For malignant effusion, the absolute HFC count was 25 high fluorescence cells per microliter. For non-malignant samples, it was just 5. Similarly, for HF percentage, we found that in malignant samples, the percentage of high fluorescence cells was 10.4%, and for non-malignant cases, it was 5.7%. This is the ROC curve, which plots sensitivity against 1 minus specificity. The blue plot is for the absolute count and the green is for the percentage. So as we can see, the area under curve for absolute high fluorescence cell count is higher than the percentage. So we determined the optimal cutoff for high fluorescence cells. At a low cutoff of 30, we found a sensitivity of 68% and a specificity of 64% for detection of malignant cells. For percentage, at a cutoff of 27%, the high fluorescence cell count was found to be 74% sensitive at a specificity of 56%. When we increased the cutoff to 72 high fluorescence cells, the sensitivity came down to 48%, but the specificity was 83%, which is quite good. So, high fluorescence cells, as we discussed, have large nuclear size and show increased fluorescence. These malignant cells also have large size and are hence counted as high fluorescence cells. So, we compared the number and percentage of high fluorescence cells in malignant versus non-malignant serous effusion, and we found that there is a significant difference in the absolute count and percentage of high fluorescence cells in malignant effusions versus non-malignant effusions. The ROC curve has demonstrated a sensitivity of 68% and specificity of 64% at a low cutoff of 30. Amongst these cases, a total of 30 cases were found to be false negative. Then we reviewed all these cases and we found that the cases which had a lower percentage of malignant cells, that is only occasional cells were seen on microscopy, were found to be false negative, because they had a lower percentage of high fluorescence cells because of a lower number of malignant cells. At a higher cutoff of 72, the specificity was 83% and only 18 cases were found to be false positive at a high cutoff. So these false positive cases were found to be having a high number of reactive mesothelial cells on microscopy. So to conclude, we have found that there is a significant difference in the number and percentage of high fluorescence cells in malignant vis-a-vis in non-malignant effusion. We have, in our experience, high fluorescence cell count is a useful ancillary technique, especially in high volume center like ours, where there is a significant cytopathology workload. So, high fluorescence cell count is an useful aid to the cytopathologist, and it gives a clue about the probability of finding malignant cells. If the high fluorescence cell cutoff is his count is low and you're not finding malignant cells, then you can easily give out a negative report. But if the HFC count is high, then you have to be very sure and you have to spend more time on the slide before giving out a negative report. These are my references. I thank you for your time and attention.
Cells for cancer. The thing is, when you have a
Yeah. Thank you, Dr. Shashank.
Thank you.